Well, it's a pleasure to be here today to honor Carol. And also, I want to thank Marty for the invitation. I looked at the schedule today, and it really kind of reflects the depth of the talent here at Memorial. It's been a wonderful relationship between our two institutions. So it's a joy for me to be here today. I'm going to talk about a different topic than I normally talk about, but this is something that we've been working on recently. There's not a lot of developed data, but I wanted to kind of get feedback from this group on this concept, and I don't have any conflicts. So molecular profiling for conservative management. So our current focus in endometrial cancer, as the two earlier talks have focused on, is looking at molecular alterations and targeting them in advanced and recurrent endometrial cancer. And it's exciting. Sitting through those talks, I think that we actually have the potential in the next maybe even 5 years to really provide true targets for patients with advanced and recurrent disease. I think our unmet clinical needs are a little bit earlier. We see a large number of women these days with both complex atypical hyperplasia as well as low-grade early-stage endometrial cancer. And really, we think that molecular profiling can improve our therapeutic approaches in this context as well. So I'm going to talk about the unmet clinical needs that we're seeing. I'm going to talk about some clinical studies that we've been doing, and then finish with some new strategies that we're thinking about. So we know that about 25% of endometrial cancer patients are premenopausal, and this is growing because of the obesity epidemic. We have a need for fertility-sparing options for low-grade early-stage disease. Most of the clinicians in the audience have seen these patients who come in sometimes late 20s, early 30s, who have endometrial cancer and have not had children. And then we know that 36% of our endometrial cancer patients are morbidly obese. And we're not talking about a BMI of 30, we're talking about BMIs of over 40 sometimes, and they have many related comorbidities. And they're not really optimal surgical candidates. They've got increased perioperative complication risks, and we need to think about conservative approaches for these women as well. So this was a meeting in Leiden that Carol was also at, and we thought about different approaches to the future management of endometrial cancer. And one of the things that this group came up with was that a priority was trials for conservative therapy in young premenopausal women who wanted to maintain their fertility, as well as the group who are morbidly obese, who are not ideal surgical candidates. So we started from this. And we really wanted to look towards how best to manage these individuals. So this is something that we all know that unlike ovarian cancer, this is a much better model for physician scientists because there actually is an intermediate step. We have access to the tissue. But we know that, that there's a gray area between complex atypical hyperplasia, which is our precursor lesion, and grade 1 endometrial cancer, that up to 40% of the time when you have complex atypical hyperplasia, you'll find a concurrent grade 1 cancer at the time of surgery. So Doug talked about the TCGA project in endometrial cancer, and one of the initiatives that we're doing at MD Anderson across disease sites is doing what's called the Pre-Malignant Genome Atlas. So we're focused on solid tumors that have a well-defined pre-malignant condition and trying to do, and this is just starting, trying to do some kind of genomic analyses on the precursor lesions. And this could help with prevention options. And so we're doing this in parallel in both in human cancers as well as in animal models. There are really good animal models for endometrial cancer, again, that have both the pre-malignant precursor as well as the cancer. And so when we think clinically about how best to approach this question, we start with progestins. We know that even grade 1 cancers are a clinically reversible disease. We can treat these individuals with oral progestins and reverse that back into normal. And over the last couple years, there have been studies, including ours, that have looked at a Progestin-eluting intrauterine device and and considering that as a management strategy. So why is that? So a lot of these very heavy women, MAGAs or other oral progestins, only make the situation worse. They may help for a short time, but they do not help in terms of weight management. So kind of the local option, and in addition, the uterus really lends itself to novel local options. So we performed a prospective phase 2 study. We had 25 evaluable patients. All of these individuals had a baseline endometrial biopsy. An IUD was placed, and they had biopsies actually every 3 months. And so our primary endpoint was the response rate at 12 months. And for CAH, we had an 88% response rate, and for grade 1 endometrial cancer, a much lower response rate, about a 50% response rate. So even though pathologically we see that a lot of times there can be a fuzzy gray line between them, from a clinical perspective and the ability to reverse the disease, there seems to be quite a difference. And we're doing ongoing molecular work now to look at the differences between those individuals who we were able to reverse with the progestin IUD versus those that we were not able to reverse. And this is just showing some of our estrogen-regulated genes that we've been working with for a long time, EIG121, SFRP1, and IGFBP1. And you can see that in the responders, there's two kind of points to look at. One is that you can't actually tell from a baseline level that someone's going to be a responder versus a non-responder. But when you look at the tissue kind of pre and post, you see that kind of classic estrogen-regulated genes do change in those individuals who are responders. So kind of the idea is if you're a non-responder, you are not as hormonally sensitive. So how do we improve beyond progestins? So we do pretty well with progestins, but we need to do better. We've been interested for a long time in mTOR inhibition. This is a study that we published in actually 2007 in the Gray Journal, and looked at the PTEN heterozygote mouse model, treated them with oral mTOR inhibition, and saw a pretty dramatic effect. So it's a hammer. So when you treat these animals with Everolimus, we really can prevent endometrial hyperplasia and cancer from developing. And so how do we bring that a little bit forward? So this is now not in the early stage cancers, but this is in advanced and recurrent disease. This was a series of studies that we did through our SPORE. This is a phase 2 study looking at patients that were heavily pretreated. We treated them with both Everolimus, which is an mTOR inhibitor given orally, combined with letrozole, and we saw a pretty dramatic response. We had 35 patients, and we had a 31% response rate and about a 50% clinical benefit rate if you include the stable diseases. But clearly, Everolimus combined with estrogen inhibition was quite successful in patients with advanced and recurrent disease. And so we wanted to think about bringing that forward a little bit in terms of looking at our conservative management. So the idea was to, we know that there's extensive crosstalk between estrogen signaling as well as the PI3 kinase pathway. We wanted to build on these studies in advanced and recurrent disease. And instead of letrozole, which really for a young premenopausal woman has a lot of kind of systemic side effects, we wanted to look at the progestin, the local progestin blocking estrogen signaling, and combining that with Everolimus. And so this is our new trial that we've just opened. So these are for individuals who are given a Mirena or a progestin IUD first. There's a lead-in period of time. They're treated on that, and again, they're getting biopsies every 3 months. If they do not reverse after a 3-month period, then we randomize them to either continuing on the progestin IUD versus getting the oral Everolimus added on. And so we'll do, again, endometrial biopsies every 3 months because the translational part is an important component of this, and we are anticipating that we'll have 80 patients total. And so what we see when we talk to our pathologists, Russell's always happy to tell us when he's looking at these samples of patients who've had response that it's very heterogeneous, that within the same specimen, you'll see areas of the tumor that have responded and have kind of that classic progestin response, and there are other areas that don't. And so we wanted to kind of think about this concept of heterogeneity and perhaps hypothesize that the clinical non-response for those people with grade 1 endometrial cancer may reflect this heterogeneity. But how do you get at that when you're doing kind of a bulk endometrial biopsy and you're doing your analyses on the bulk tissue? And so we've worked with Sam Mock, who does a lot of genomics off of microdissection, and we're starting to do single gland microdissection. So we're able to microdissect single glands within an endometrial biopsy and compare those glands. And then the other really important part that's much more relevant in the earlier pathogenesis of endometrial cancer is that crosstalk to stroma. And so this allows us to microdissect the glandular area as well as to microdissect the stromal area and to really evaluate this crosstalk. And so this is just kind of an example of how we do this. So we procure individual glands from normal endometrium, and this is not necessarily the same patient, but different patients, hyperplasia and cancer, and we isolate both DNA and RNA, and we do our genomic analyses. So this is just very early work. We actually have a hard time, as I imagine you do, in terms of getting normal tissue. So we had a couple of normal endometrial cancers and did individual gland analysis. And what you can see here is that, and these are individual patients, that the normals tend to all be fairly homogeneous, and they track together by patient. But when you look at the tumors and you look at, so each letter here is a different, is the same patient, but like A1 and A2 would be different glands from the same patient, that from a tumor standpoint, we have a lot of heterogeneity within the same patient. So one patient is going to have different populations within their cancer, and this may be the reason that we see differences in terms of response to progestins. So we're also working on stromal and epithelial crosstalk, and so we're working with a group at Methodist that's developing these networks, and so we're able to kind of apply this software to our genomic analysis and look at networks and analyze populations of patients that respond versus populations of patients that don't respond, and not just look at the individual glands, but also look at networks of stroma and epithelium, which again I think is really particularly important and when we're talking about earlier in pathogenesis and complex atypical hyperplasia and grade 1 endometrial cancer. And so this is kind of the general idea of what we'll be doing is we'll be, these are kind of the places that we're going to start. So we're going to start looking at individuals who have progestin-resistant and Everolimus-resistant tumors. Kind of the extremes are always the easiest to look at when you're doing discovery. So we'll look at those cases and compare those to patients who are progestin responsive. Again, this is more of a discovery phase and try to identify biomarkers that will potentially help us triage individuals to just Mirena alone, but perhaps earlier treatment with both Mirena as well as Everolimus. And that's what I just said. So I'm just going to end talking about something that we've been working on for the last 2 years, and it's this concept that will match with what we're doing, and that's this innovative drug delivery system. So we're working with Rice University to develop a novel intrauterine drug delivery approach. Endometrial cancer is particularly useful because you have access to the organ, and so the concept is to develop a polymer formulation for sustained intrauterine delivery of something other than progestin. So it's already been done for progestin, and so we wanted to look at other polymers to be able to embed specifically an mTOR inhibitor. So as we were looking into this, we realized that actually it's already being done in the heart. So there are stents that are embedded with an mTOR inhibitor, and they're being used clinically. And so we thought if you can embed it in a cardiac vessel, we can certainly embed it in the uterus. And so we've already done the pharmacokinetics for doing this, putting it into a polymer, and basically different polymers will elute differently, and so we're kind of aiming for a longer-term elution and working with the team there. And then we would embed both Everolimus or just Everolimus into what's called Next-Generation IUDs. There are a couple of different models for Next-Generation IUDs, and you can see them here. You can actually embed the polymers either in these little balls or kind of in these little areas, and then once they go into the uterus, they're actually called IUBs instead of IUDs, intrauterine balls. We're working with the National Primate Research Center in Oregon, and they do a lot of contraceptive research. They're so already doing work with contraceptives in their baboon models, and so they'll be working with us first with the polymers alone, and then with these models. So that's it, and thank you so much for giving me the opportunity to talk.